This recording is going to cover antepartum material. So we are going to cover kind of like prenatal information, as well as talk a little bit about preconception visits. So there are some women that might come in for what's called a preconception, like counseling visit. So this is prior to pregnancy, okay? So this is a visit where we would encompass a lot of the education that we would likely to provide somebody that just recently found out that they're pregnant. So we'll give recommendations about like healthy nutrition, making sure to have as much of those vitamins and nutrients met through their diet, encouraging them to like start prenatal vitamins, avoid things that can be harmful to pregnancy, such as like drinking alcohol and other substance use. So that is kind of what preconception counseling will cover, is just some things that we can educate the mother on, or I guess she's not a mother yet, but the patient on, to kind of have a healthy state prior to pregnancy occurring. Now, the other part of preconception visits is genetic testing. So if a woman has experienced multiple miscarriages or isn't able to like hold or maintain a pregnancy, or maybe she's even had a child that was born and had a chromosomal abnormality. So in those different cases, we can do what's called genetic testing, okay? And this is where we'll do like a DNA analysis or karyotyping of her, grab a blood sample from her, and we'll look at that to see if we can see if mom and dad are carriers for anything. Usually we will start, testing with mom, and then that will be followed with testing of dad. But every provider is going to do it a little bit differently. And sometimes providers might just do both mom and dad's tests at the very same time. So this can just be really helpful again in understanding if there's anything chromosomal that's causing some of these possible miscarriages, early losses, or anything like that. So I like to just kind of share about my experience with this. I had multiple miscarriages. I had 4 miscarriages. And so we did genetic testing. And when we did our testing, me and my husband were tested at the same time. My testing came back clear, like I didn't have any chromosomal abnormalities, or I was not a carrier for anything. But my husband's test actually came back as positive because he was a carrier for cystic fibrosis. And although that wasn't playing into my miscarriages, it was still really helpful information to know, you guys, because that's going to be helpful for when our daughter has a pregnancy. And so now that she knows that her father was a carrier, that she's going to want to probably get testing done herself as well as her partner, because if she marries someone who's also a carrier, then we know that there's that increased likelihood that her child could have cystic fibrosis. So again, some really helpful information for patients, and things that they can pass along to their future children as well. This slide is covering the different signs of pregnancy. So you can see that we have them divided out between presumptive, probable, and positive signs of pregnancy. So you do need to be familiar with what symptoms, like where symptoms are categorized. Are they presumptive, are they probable, or are they positive? Okay. So I kind of have a way to kind of help you think about how to break up these symptoms and be able to categorize them more appropriately. So with presumptive, I want you to think about the things that a woman herself would be experiencing. So these are more subjective symptoms, okay? And presumptive are going to be the least accurate because there's a lot of things that could cause some of these symptoms. So those are going to be things like your breast changes, nausea and vomiting, amenorrhea, frequent urination, fatigue, uterine enlargement, as well as the skin changes that we see with pregnancy. Now, your probable signs are going to be more of those physiological or anatomical changes detected by a healthcare provider. So these are going to be more objective. However, they're still not like you can't use these symptoms to rule in definitively pregnancy. Okay. So these are going to be things that, again, the healthcare provider could examine. So we could look for like Chadwick sign, Goodell sign, Hager sign, fetal outline by the examiner, ballottement, as well as a positive pregnancy test. The reason why a positive pregnancy test is listed under probable is just because there are those tumors that could secrete the same hormone that we detect with pregnancy tests. So therefore, again, it's not completely absolute, okay? Now, your positives are the easy ones, and these are the ones that I would just encourage you to really memorize because there's 3 of them, okay? So that way it helps you to remember, okay, well, I know for sure that these 3 are the only positive ones, and then you have to decipher between probable and presumptive for those other listed out symptoms of pregnancy. Okay, so for your positive, it would be a sonographic evidence of fetal outline, hearing those fetal heart tones, or fetal movement felt by the examiner. Okay, so hopefully that helps you guys in understanding the differences between those different signs and how we categorize them. This slide is giving you some information on how we calculate their estimated due date or their estimated birth date, okay? So what we're going to use is their last menstrual period to be able to calculate that. And it's a method called Nagel's rule. Now, today, it's unlikely that you're going to be completing this in clinic because we have these amazing computers and technology that does it for us. But we still want you guys to be able to calculate this properly, and you will be tested on that. So make sure you're feeling really comfortable with these different problems. So when we talk about Nagel's rule, it's a system where we're going to count backwards 3 months from the first day of a woman's last menstrual period and add 7 days. So I gave you an example here. If a person's last menstrual period began May 15th, we would count backwards 3 months. So that would bring us to April, to March, to February, okay? So we got to February, then we're going to add 7 days. So again, we saw that it was May 15th, so that would bring us to February 15th, and then we're going to add 7 days, which brings us to February 22nd, okay? Then you have to think about the year. So remember that pregnancies last for approximately 40 weeks. So we need to calculate that and determine, would this be the same year or would it be the following year? Okay, so in this problem, it would be the following year. So if it was May 15th, 2022, then it would be February 22nd, 2023 for that due date. Here's another practice problem. So we have a client that has come in for her first prenatal visit. She is trying to establish her EDB or estimated date of birth. She tells you her last menstrual period ended on June 8th. She also states that her bleeding usually lasts for approximately 7 days, and it's pretty consistent. So when is her expected due date? Well, if you look at this problem, there's an extra step that we have to take because she told us that her period ended on June 8th. Remember, we're always looking for that first day, but she does tell us how many days she usually bleeds. So we can calculate that. It's just that extra step prior to Nagel's rule. So knowing that her period it lasts for 7 days, we will just subtract that from June 8th and get to June 1st. If she bled for 5 days every month, then we would only subtract 5 days. Or maybe it was 8, then we would subtract 8, okay? So she said 7, so that brings us to June 1st. Now we're going to use that Nagel's rule. So June 1st, subtract 3 months. That brings us to May, to April, to March, as you can see. So we land on March there. So then we're going to go from March 1st and add those 7 days, and that brings us to March 8th. and then we would want to add the year. So in this problem, it would be March 8th, 2022, okay? So hopefully that problem helps a little bit as well. Here are some extra practice problems. So I would like you at this time to pause the recording, give yourself time to practice these, and then I will go over the answers for you. So please pause the recording now. Okay, so I just want to go over a couple of these problems. So during a prenatal appointment, patient tells you last menstrual period was May 21st, 2022. So based off of Nagel's rule, when is that estimated due date of her baby? So we got to use Nagel's rule here. Okay, so that would be going back April, March, February. Okay, so we land on that February. We're going to add 7 days. So that would bring us to February 28th. And then we have to think, what year would that be? Well, it would be the following year, given that a pregnancy lasts for 40 weeks, right? So February 28th, 2023 would be the correct answer for that one. Let's go to the next one. During a prenatal appointment, a patient tells you her last menstrual period was November 25th, 2022. Based off of Nagel's rule, when is the estimated due date of her baby? So again, we got to use that Nagel's rule. So we're going to go and subtract 3 months, okay? So that would be October, September, August, okay? So then that puts us at August 25th, and we have to add 7 days. Well, with this problem, we also have to know how many days there are in August, and there are 31 days. So that we have to think about that when we're adding those 7 days. And when we add 7 days to that, that actually brings us to September 1st then, you guys. So that would be September 1st, 2023 then, okay? Next problem. During a prenatal appointment, a patient tells you she doesn't remember the first day of her last period, but she knows her last day of bleeding was March 14th, 2022. She always bleeds for 5 days. So we have that extra step on this problem, okay? So if we take March 14th and subtract the 5 days, because that's how many she bleeds for, then that would bring us to March 9th, right? So now that we have March 9th, let's go into Nagel's rule. So following Nagel's rule, we're going to go backwards those 3 months, okay? And that is going to bring us to December, okay? So then December 9th plus those 7 days is going to bring us to December 16th. We need to think about the due date, or excuse me, the year. So when we're looking at this, remember pregnancies last for 9 months. So would that be in the same year or would it be a different year? Well, that would be the same year, okay? So make sure that you guys are paying attention to that. So that would be December 16th of 2022 then, okay? Last problem. Patient presents to the emergency room complaining of lower abdominal cramping, lack of menses. Patient reports the last day she remembers having any menstrual bleeding was New Year's Eve of 2021. Patient reports that she remembers her period started that month on Christmas Eve. Based off of Nagel's rule, when is her estimated due date? So some kind of tricky information happening here, but we know that she states that her period started that month on Christmas Eve. So that would be December 24th then, right? Because Christmas is December 25th. So then we're going to want to count backwards those 3 months. So that would be November, October, September, right? So then we're going to have to do September 24th plus those 7 days, guys. Think about how many days there are in September, and then that would result in October 1st for your due date, okay? So just remember again to calculate that properly using how many days there are in each month. There is a trick to that if you look up like using your knuckles. I've seen a lot of students do that, and that was really helpful. So check that out, Google it if you'd like, to help you be able to remember which months have how many days, okay? Oh, and then I forgot to add the year to that one. So knowing that it was December 2021, then we would know that it would be the following year since it's the end of that year. So that would be 2022 then for that one, okay? Hopefully those practice problems helped. The next thing I want to talk about is understanding OB charts and the gravida and parity that you see. So a lot of times you might see shorthand or longhand in a lot of charts. And in this one, you can see I have the shorthand up there that tells you how many pregnancies and how many pregnancies in total she's had. And then the P in this one is defined as the number of times she has reached viability. So that 20 weeks mark. Whether the fetus was born alive or stillborn. So I gave you that example there of a G2P2, and that would mean that she's had 2 pregnancies and 2 deliveries after 20 weeks, okay? So that is shorthand, just so you're aware. And then we're going to kind of cover that G-TPAL system a little bit more in detail. So this is more that longhand. And depending on where you practice, you might see either the longhand more often or the shorthand. The nice thing about the longhand with this G-TPAL setup is it tells you a lot of information about your patient just based off of this, like, this number system, which is super, super helpful. So again, your G is going to be gravida, and that's going to be the number of times a woman has been pregnant. So this number is going to include all pregnancies, you guys. So regardless of those outcomes. So even if it was a miscarriage, you're still going to count it in the gravida, okay? So again, all pregnancies are counted there. And then, like I said, this is going to be a longer hand, so a 4-digit system. And we're going to use kind of these mnemonics or acronyms of TPAL. So you can see there that your first one is going to be T for term births. So term births are recognized with births occurring after 37 weeks, okay? So if they're in that 37th week, even on that first day, it's still considered a term delivery. Preterm is going to be any birth that's occurring between 20 and 37 weeks, okay? So you can see that 37 weeks there. So what we put in parentheses can help you kind of dictate whether something would be preterm or term. So with your preterm, if she's in her last day of her 36 week, that would still be considered preterm. But as soon as she jumps to that first day in her 37th week, then that would be considered term. So I hope that helps you be able to differentiate that a little bit better. The A is going to be for your abortions. So this is going to include all pregnancies ending in spontaneous or induced abortions. So spontaneous, remember, are going to be those miscarriages. And then this also refers to any fetus that was delivered before 20 weeks. So we would incorporate that in the A number as well. And then the L is just living children. So we would want to record the number of children currently living, okay? So that's the TPAL system. Remember too that if she is pregnant with multiples, that will count as one birth, okay? So that will count as one for your gravida, and that will count as one in your T, P, and A. The only time that we would count more than once for like a multiple is in the living children, right? Because we might, if it's twins, we would have 2. If it was triplets, we would have 3. And a lot of times too, there will be like a note section to also explain the numbers there. So let's practice kind of developing or using this G-TPAL system. Amelia presents to clinic for prenatal care. So that means she's pregnant. She arrives with her 3 children, 7-year-old Johnny, 3-year-old daughter Susie, 1-year-old boy Derek. All of them are obviously alive. She reports that she did have 2 miscarriages prior to her oldest, Johnny. She shares that Johnny was born at 38 weeks, so we know that's a term birth. Susie was born at 35 weeks. Okay, that's a preterm. And Derek was born at 37. Again, that would be a term. So the first 2 births were vaginal deliveries, and her last one was a C-section. Filler. Don't even need to know that. She reports that she has never had an abortion by choice. Okay. What is her gravida and para status? Well, we have to count up all her pregnancies. So through that problem, we know that there was Johnny, Susie, and Derek. We also need to remember that she reported 2 miscarriages, okay? And she also said never had an abortion by choice. So we count that in there too, just knowing that there was no abortions, but those 2 miscarriages. And remember, we have to count her current pregnancy, okay? Because she's coming for a prenatal care. So that's what you have to think about. So prenatal, she's pregnant. Preconception, she's not pregnant yet, okay? So counting all those up, that would give us 6. How many term pregnancies? Well, we know that Johnny was born at 38 and Derek was born at 37. So that would be 2 that we would put for our T, okay? How many preterm pregnancies has she had? Well, we know that Susie was born at 35, so that would be 1 preterm birth. How many abortions has she had? Well, she told us that there was no abortions by choice, like elective abortions, but she did report spontaneous abortions or those miscarriages, and she said she had 2. So for our A, we would put a 2. Last, how many living children does she currently have? Well, she brought Susie, Johnny, and Derek to her appointment, so that would be 3 living children. So for that longhand, you would write out G6P2123, okay? Don't let this P throw you off. That is just recognizing that parity or that para. And basically that term is saying like, hey, here's the breakdown more specifically of all those pregnancies. And the first number is your T, second is your P, third is your A, and the last one is your L. So just remember that it's in that T-PAL order. So G6, P2, 1, 2, 3. Okay? So I'm going to pause. And again, here are some practice problems for you guys. So take a moment, look at these, look back at the other slide to help you work through these and see if you can achieve writing out her GP status or G-TPAL status. I want the longhand, okay? So I want to see that G-TPAL for all of these problems. So pause the recording, please. Okay, that first problem, a patient is pregnant with twins. Okay, so she's currently pregnant, right? So we know that that would be 1 pregnancy. So you'd want to write that out. She has a 5-year-old son at home. Okay, she has a 5-year-old, so that is another pregnancy that she had. Okay, she's had no miscarriages or elective terminations. Well, that's good to know. Patient had her son at 39 weeks. Well, we know that that would be term, right? What is her current gravida and para? So we know that she had those 2 pregnancies. So G, that gravida would be 2. Then we have to write out that T-PAL. So term pregnancy, she would have 1, right? Because her 5-year-old was born at 39 weeks. She has had no preterm, and she's had no abortions, no miscarriages or elective, and then she has 1 living child. So your total answer would be G2P1001. Or you might also see it as G2T1 P0, A0, L1, okay, to kind of fully see for a visual what that T-PAL is. Next problem. Patient comes to you to see, or for you to see her for her first prenatal visit. Her dating ultrasound shows a viable single intrauterine pregnancy at 6 weeks, 5 days. Patient's obstetrical history includes 2 children at home born at 37 and 40 weeks, 1 miscarriage at 9 weeks, and 1 elective termination at 12. What is her current gravida and para? Okay. So you have to look at the problem and make sure that we can calculate that gravida, which is all pregnancies. So she's currently pregnant. Okay, so we have to count that one. So that would be 1. She has her 2 children at home, so her 37-weeker, and then also her 40-weeker. She had that 1 miscarriage, and then also 1 elective pregnancy, or elective abortion, termination at 12 weeks. So when we add all those up, that would be 1, 2, 3, 4, and 5. So her G would be 5, okay? Then we need to break down that T-PAL status. So looking at the problem, you can see that she had both her children and they were term pregnancies, a 37 and a 40 week. So your T would be 2. You can see also that there was nothing said about any preterm pregnancies. So that one would be a 0. Okay. Then for your A, she talks about the miscarriage and the elective termination. So we know that that would be a 2. And then she has her 2 children at home. So her full G-TPAL status, that's a mouthful, is G5P2022. Another way that you could write that out is G5T2P0A2L2. The other part of this problem states, what will her gravida and para be after she gives birth to a living baby at 38 weeks gestation? So there's 2 parts to this problem. Well, the only numbers that would really change is the T, because that's another term pregnancy, and the living children, right? Because we are already accounting for that pregnancy. So then it would be G5P3023. Now, your last problem, you see on your patient's chart, her gravida and para is listed as G2P1002. How many times has she been pregnant? Well, that would be twice, right? How many term deliveries? Well, that first number after the P would be 1, because that's your term. How many preterm deliveries has she had? 0. How many abortions, spontaneous or elective? That would be 0 too. And then how many living children does she have? It says 2. So wait a second. She's laboring right now. And so why would there be a 2 for living children? Because technically she hasn't delivered yet that second child. Well, that would mean that her first pregnancy, you guys, was twins. Okay. So hopefully you guys were able to sort through that, because that can be a little tricky. This slide is covering just kind of some imaging and testing that would be done with that first prenatal visit. So a lot of the times we're going to do an ultrasound to confirm that last menstrual period or that due date. So that's something that will get scheduled for that patient. Then there is a good amount of lab work. So you can see here that we're going to collect a urine, we're going to do a CBC, we're going to do some testing for syphilis. If that ever did come back positive, we must treat it. We'll do blood typing and Rh factor to identify if she needs RhoGAM, cultures for chlamydia and gonorrhea. We're going to also check to see if she's got antibody titers for rubella, hepatitis B and C, and varicella. If she's needing vaccines, remember that we won't be able to do any of those live vaccines, so she would have to wait until postpartum to get vaccinated. We'll also do HIV screening. We'll check her hemoglobin. And then also, if she's got risk factors, we will check her hemoglobin A1C and try to, and also just check that out and maybe follow through with a gestational diabetes screening earlier on. But again, that is if we have risk factors. So that would be things like a BMI over 30, or if when we did our like urine test, we noticed that there was some glucose in the urine. So again, hemoglobin A1C, if they either had a history of gestational diabetes, maybe a history of macrosomia. So those are those babies that are greater than 4,000 grams. Or if she has a BMI over 30 or some glucose in her urine. Otherwise, we'll wait later on in the third trimester to do her gestational diabetes screening. We'll do a pap smear on her if she's not up to date on that or if it's going to be needed soon. If she's experiencing any symptoms like of a yeast infection or of bacterial vaginosis or possible trick, we're going to want to do a wet mount for that. And then we'll do TB testing for people that are at risk or have risk factors. And then genetic testing depending on weeks gestation, okay? Because depending on the different tests, those can only occur during certain weeks of the pregnancy, or she has to be so far along for certain tests. This slide is just covering the health history. Remember, we're going to be pretty extensive with that history and that collection of information, because again, all of this information is going to be helpful in us to be able to help her have a healthy pregnancy and know all those risk factors that could put her, you know, at risk for certain complications in her pregnancy as well. So you can see here, it's pretty lengthy. We also want to know her partner's history. We do want to know that OB history, her sexual history, use of contraceptive, also her social history. So when we think about social history, I want you to think about things like substance use, her work environment, seeing if there's any of those environmental exposures that you see towards the end there, just because we're looking for potential harms to that pregnancy or those teratogens. And then we always do a safety screen and intimate partner violence screening, as well as depression screens. History continued. So some initial questions. We do want to get that demographic data. So that way we have that in the chart and can identify if there's any like cultural considerations that we want to verify with them or incorporate when we're working with them, going through their prenatal care, as well as when it comes time to develop their birth plan. Your chief concern, obviously, reason for visit is probably going to be related to that pregnancy. Again, we're going to want to use that Nagel's rule to document her estimated due date, ask about those different signs of pregnancy, if she's been experiencing any discomfort or if she's been feeling fine. We're going to want to educate about danger signs and ask if they've been experiencing any danger signs, such as like bleeding or cramping. And then if the pregnancy was intended. Because we don't want to jump into a visit, you guys, and just assume and congratulate people, because this could be a pregnancy that was unwanted. So make sure that we go in neutral. And in those cases, we do have to provide her with the options and do our best to be, again, unbiased and be very neutral when we're discussing her options for that if she's not wanting to follow through with the pregnancy. This slide is just covering the different pieces of the head to toe exam that we're going to want to do. Again, we are going to be doing a pretty extensive exam on her, so it will be a pretty thorough head to toe. And then we're going to also want to make sure to hit that review of systems to make sure that we're not seeing any signs and symptoms of any concern. So making sure to go through each system to ask those questions, those review of system questions. So here I kind of laid out on the slide for you the different systems, some signs and symptoms, and some considerations and actions as well. So I'm not going to go through this in detail since this is available for you guys to go back and look through and study on. So that way you can understand the different things that we're going to incorporate into that exam. The other portion of the exam would include a pelvic exam. So this would be something that we would want to incorporate and just examine the external genitalia, making sure that we're not seeing any signs of like inflammation, infection, ulcerations, or lesions, or maybe some vaginal discharge to where we want to do a wet mount because we're concerned for like trick or other STIs. We want to make sure and look to see if there's any like vulva lesions that could possibly indicate things like herpes simplex type 2. And then also just kind of examining that vaginal muscle wall support, asking her to bear down, noting any conditions such as like rectocele or cystocele. Internal genitalia, we will inspect that cervix and vagina. So this would be done with a speculum. So we will just see, is the cervix centered? Is it anterior? Is it posterior? It could be in a different spot for other women. So making sure that we can kind of locate that and mark that in our charting. How's the color? How's the shape? Is there any lesions, ulcerations, discharge, or abnormalities? Because remember, we would see some of those things with certain STIs as well. Again, obtain that pap smear if she's needing one or is going to be due for one soon. And then again, that wet prep if we're noticing any symptoms, if we feel like it's indicated. This could also include what's called a bimanual exam, where we are placing our fingers inside to assess the position, contour, consistency, and tenderness of those pelvic organs as well. So that's what this slide is covering for you. This is a breakdown of just assessing the fundus and the fetal heart tones as well. So you can see I kind of broke it between the different weeks because depending on how far along she is, that's going to dictate how we're going to be doing our exams. So weeks 6 through 11, you can see we'll be doing a bimanual exam. The uterus is still considered like a pelvic organ, You'll see here that during this time, dating by ultrasound is going to be the most accurate between that 7 to 11 weeks. 6 weeks, we could expect it to be the size of a small juice orange, 8 weeks, the size of a navel orange, and 10 weeks, the size of a grapefruit. When she gets to weeks 12 through 20, we'll use what's called finger breadth measurements, and that is literally just using our fingers. That's roughly the same as like a centimeter. So now the uterus is considered an abdominal organ. So uterine size is going to be used by us using our fingers to palpate and estimate the proximity to certain anatomical landmarks, such as the umbilicus or the symphysis pubis, okay? So I know it seems silly or kind of weird that we use our fingers, but honestly, that's what we find to be still most accurate. 12 weeks, that will be kind of at the level or right above that symphysis pubis. 16 weeks is going to be halfway between the symphysis pubis and the umbilicus. And then 20 weeks will be at the level of umbilicus. So you can see in the image there, based off of weeks gestation, where we would expect to find that fundus. Remember, the fundus is the top portion of her uterus, okay? Weeks 20 through 40, we'll start measuring with a measuring tape to assess uterine size and growth. Normal is going to be considered between like 2 centimeters plus or minus her weeks of gestation. So if she is 24 weeks, then we would expect her to be sitting between 22 to 26 centimeters. Okay. So again, plus or minus 2. But we would also want to see consistencies with that. So keeping that in mind too, we would be really concerned if she was measuring, say, at 18 centimeters at 20 weeks, and then at 24 weeks, she was all of a sudden measuring 26 because she's on the opposite spectrums there. So that would be something that we'd maybe want to investigate. After 36 weeks, this method becomes a little less accurate just because that fetal head starts to descend into the pelvis. So that's something just to keep in mind as well. In regards to fetal tones or fetal heart tones, excuse me, usually we can start auscultating these or find these with a Doppler around that 10 to 12 weeks time, but that also depends on placental location and maternal habitus. So again, from there on out, we'll continue to measure those fetal heart tones. Different topics that we're going to want to educate on. Hopefully you're feeling a little bit better with some of these topics since we've hit them in our other kind of lectures and PowerPoints. But if they did not have that preconception visit, we will want to make sure that we discuss like nutrition and fluid intake, those different teratogens that could be harmful to pregnancies, including those different foods that we talked about, making sure that she's staying on top of taking her vitamins. Remember, prenatal vitamins, that folic acid. So making sure that we're checking her prenatals to make sure that it has that in there. What we would consider healthy weight gain in pregnancy based off of her BMI. The different genetic testing options that she has available to her. Remember, that's shared decision making. So it's patient's choice, and we can just educate about pros and cons with that. And also, it just depends on if that's going to dictate her, either terminating her pregnancy or moving forward with her pregnancy. So those are some really good discussions that we can have with the patient. And then common discomforts and relief measures. So it's really good to provide that anticipatory guidance, which is, hey, in the next few weeks, you might start to experience these symptoms, okay? Especially when it comes to that nausea and vomiting, and also letting them know when they can start to see those symptoms start to like go away or become more alleviated from the nausea and vomiting. So other things that we could offer them is just kind of relief measures too. So a lot of women will feel really nauseous when they are taking their prenatal vitamin. So a lot of times I might educate them to take it at bedtime so that way they're not having that nausea and vomiting. And then also it's kind of helping them since they're just going to be going to sleep right away. Other things, it would just be like having hard candies to suck on at times, or placing crackers and some water right at the bedside. So that way, if it's hitting them straight away in the morning, they could eat some crackers and have some water to alleviate some of that nausea as well. Teratogens. So this is just covering different things that could be harmful to the pregnancy. So we do want to make sure that we are educating and screening for the different possible teratogens that could be harmful. There's a lot of things that can unfortunately be harmful to pregnancy. So we have to be thinking about all those different things. So as you can see here, we have to think about those, that TORCH testing too. So toxoplasmosis, syphilis, hepatitis B, rubella, cytomegalovirus or CMV, and herpes simplex. So a lot of those, teratogenic maternal infections involve viral bacteria, they're protozoan organisms, and those can cross that placenta from mom to fetus, you guys. Most infections that may detract from like a healthy pregnancy outcome cause relatively mild flu-like symptoms in the woman, but could have a lot more serious effects on the baby as well. So again, we want to make sure that we're screening for those. Some other teratogens could be things like your live vaccines, certain drugs and medications. There's a lot of the medications that people take, like mood stabilizing agents, that could be teratogenic for pregnancies, recreational drug use. So we do want to make sure that we're trying, again, to screen for all those things and providing education on those things. This slide is just covering the different tests that we complete, the prenatal and genetic testing. So I really like this image, you guys, because it does a really good job of showing you kind of the routine testing that we would complete in the different trimesters, and then the non-routine testing. So those things are more optional. And again, that shared decision-making process that we might have with patients, or for instance, in that non-routine third trimester test, that might be stuff if she's going past her due date and we're wanting to do some more monitoring of baby to make sure that baby's still cooking okay inside mom. So those are some things that we might you might see being done towards the end of that pregnancy if she's going past her due date. So again, just make sure that you're feeling familiar with those routine tests for first, second, and third. And those are going to be things like your pregnancy tests, your blood tests, your urine tests, your ultrasounds, where you also have the option of that first trimester screening with maternal blood serums and nuchal translucency. So if she is interested in different genetic screenings, those would be included there. Second trimester tests, we're going to continue with urine screens. We're going to be checking for those fetal heart tones. You're going to have that glucose challenge test around that 28 weeks. She could also opt in doing a quad screen, and then we have that anomaly ultrasound at 20 weeks as well. Third trimester tests, again, we're going to continue with urine tests, fetal heart tones. Group B strep is going to be collected at 36 weeks, and then we're also going to do fetal kit counts. Your non-routine is going to be involving genetic screening tests as well as, or screenings as well as genetic tests. So genetic screenings, keep in mind, these are the type of, can kind of be confusing to explain. So screenings are going to kind of identify the patients that are at risk for something. So these are going to be recorded as percentages. Okay. So for your genetic screening tests, those are going to be like, hey, this patient has a, 25% chance of having a baby with Down syndrome, or maybe they have like a 80% chance of having a child with Down syndrome. So what we'll do a lot of the times is we'll do these screenings first, and then depending on how those screening results come back, that is what's going to dictate us following through with doing genetic testing. So your genetic tests are going to be more like your amniocentesis and your chorionic villi sampling. So those are things that we'll complete, and those will give us more of a definitive like yes or no that the baby has this. Okay. So I just kind of wanted to take a moment to explain that to you too. This slide is just covering a little bit more information on an amniocentesis. So if a patient does have an amniocentesis, it will feel like a lot of pressure when that needle is inserted. So we do want to make sure to give them some good education. I do believe that your ATI material does cover a little bit of that information as well. So make sure to look at your ATI textbook for that. I really like your guys' ATI textbooks because they do kind of just like get straight to the point and keep it simple with all the information that they present. If you do want some more information, understanding like genetic screenings and genetic tests, I have provided some really good videos for you guys. So please feel free to click those links, and they will help you better understand the different screenings and tests that are offered to women. This slide is covering kind of that visit schedule and that anticipatory guidance that I talked about. So you can see for your prenatal visits, we're going to do every 4 weeks up to that 28-week mark. And then we're going to do every 2 weeks from that 28 to 36 week. And then weeks 36 through 40, we're going to do weekly. Post-dates fetal surveillance will occur between those weeks of 40 to 42. Your visits will include things such as like your vitals, weight gain, fetal heart tones, fundal height measurements. We'll look at past labs if we collected any from the previous visit, so that way we can go over those with the patient and then identify any concerns or problems and review the history from the last visit. So that way we can stay on top of everything, or at least the patient's concerns, and see if those concerns have resolved. 12-week visit, that is where we could offer some of the genetic screening tests. We could talk about how hopefully that nausea relief will be anticipated soon. Start talking about some recommendations for heartburn. Again, listening to those fetal heart tones. Second trimester, remember, we're going to have that fetal anatomy survey via ultrasound. And if they want to do a screening, we could do another genetic screening test at that time. Third trimester, that's going to be your glucose screening test, your CBC, antibody screen, and RhoGAM if they're Rh negative. We'll offer a Tdap vaccine if they're needing an update on that. Discuss kind of like some preterm labor warning signs and fetal kick counts, and how we want them to be recording those kick counts on a regular basis, daily basis. And then also encourage them to partake in some childbirth education or some classes. 36-week appointment, that's when we're going to be doing a Group B strep swab. We'll assess kind of that fetal position and estimated fetal weight, and we're going to kind of start to review their birth plan and what that looks like for them or what they desire. And then 40 to 42 weeks is when we might be doing some fetal surveillance testing to make sure, again, that baby's still doing okay and has really good fetal heart tone status. And if we're starting to see some concerns, then we might talk about induction or even C-section if we're really concerned about anything. This slide is covering fetal movement, you guys. So DFM on this slide means decreased fetal movement, okay? So towards the end of pregnancy, as I talked about, depending on your provider, they might kind of inform you when they want you to start performing those fetal kick counts. So sometimes it's around that 28 week, as you can see here. Sometimes it's more towards the end of pregnancy, around like the 30 weeks. So again, it's going to be a little bit more provider dependent, but we do want to make sure it's towards the end where they will be able to more accurate, be able to like assess those fetal kicks. And we want them to do it at least once a day. You can see here that this little image says even twice daily. Ideally, if they are checking this on a daily basis, making sure that it's at the same time each day. So that way they know when kind of baby has these more active states, because baby will have some quieter states or resting times to where baby might not be moving as much. So we do want them to kind of choose those times where baby is a little bit more active. And then we want them to kind of sit comfortably or lie on their side and just kind of record how long it takes for them to count those 10 movements. We should have them feel 10 movements in 2 hours or sooner. And if they're not, then that's when we should be notified. So some things that we could recommend if they're like, gosh, you know, I feel like maybe it was 9, maybe it was 10, I'm not sure. We could just say, hey, what were you doing? Were you making sure to just pay attention to your fetal kick counts? When's the last time you ate something? When's the last time you drank something? Because those things could also impact fetal movement as well. So if they want to drink some juice, then that might elicit some more movement from baby. Other things is just seeing if they are a smoker. We don't want them smoking prior to engaging in fetal kick counts. So just making sure that we kind of hit those other topics too. But if they are still feeling pretty concerned, then we're going to want to follow up with them and have them come in. We'll probably put them on the monitor so we can assess baby. On the left-hand side here, again, you can see some pregnancy factors associated with decreased fetal movement, and then also some outcomes that might be associated with decreased fetal movement. So make sure to take a look at those as well. Rh negative moms. So Rh negative status, this is referring to somebody's blood type, okay? So when we have a mom that is Rh negative, we're going to want to make sure to give her a injection called RhoGAM, okay? This is a little confusing to explain, and maybe we can go over this in class. I usually like to use like the whiteboard and kind of draw out a scenario for you. So if we have mom, okay, and she's pregnant, and we know that mom has a negative blood type, okay? And so her baby, we won't know baby's blood type, but let's just say that baby's blood type is positive for now, okay? So mom is going through her pregnancy, all is good. However, towards the end of her pregnancy, let's just say mom missed some of her visits, okay? So she's not going to a lot of her prenatal visits. Therefore, she wasn't able to get that RhoGAM that she would technically need because of her Rh negative status. So mom never got RhoGAM. That's what we're going to say in this scenario, okay? So mom goes in and she delivers her baby. Well, with that delivery, there's a mixture of blood that happens, okay? And we're going to say baby has a positive blood type. So that positive blood from baby is mixing in with mom's. Well, mom's cells, we're going to say, almost look like little circles, okay? So they're just these tiny little circles, whereas baby cells maybe look like little sunshines, okay? So when those sunshines kind of mix over with mom's, all of a sudden her body is going to say, wait, these don't look like our cells. We don't have these little spikes off of our cells. This is foreign. So because this is foreign, we need to attack this. So then her body is going to make some army cells to try and destroy those baby cells that look like those sunshines, okay? This is like the best and most simplest way I can explain it. So now mom has these little antibodies, okay, this little army of cells that is like, yep, okay, we're ready. So if we ever come in contact with those sunshine cells again, like we know that we need to attack them, and we'll be able to get that done quickly now that we have this response or these antibodies built. So baby and mom, happy, healthy, okay, because it was her first pregnancy. So really no concerns with that. However, mom is going to get pregnant again. So mom gets pregnant again. So with the second baby, we're going to say it is, again, Rh positive. We know that mom's Rh negative. So now, you guys, we have to understand that there's certain cells that can cross over into the placenta and certain cells that can't. Well, those antibodies that mom developed, guess what? Those can cross over into the placenta, okay? And all of a sudden, those antibodies are going to say, oh, we came in contact with these sunshine cells again. Here they are. Let's destroy them, okay? So if we're destroying baby's red blood cells, we can see how that is going to be extremely harmful to the pregnancy and could result in fetal loss. So it is really important to identify Rh status of a mom, so that way we can make sure to give her that RhoGAM. What that RhoGAM is going to do, you guys, is it's going to basically prevent her immune system from responding and developing those antibodies. So hopefully that makes sense. But if you guys do want a better visual or want me to draw that out in class, just remind me and we can try to go over that. Okay? Because I know that this topic can be a difficult one. So again, this is just talking about that Rh negative mom. And so here are the different times where we might want to consider giving RhoGAM, which is listed at the bottom of your slide here. And you can see things like miscarriage, induced abortions, ectopic pregnancies, amniocentesis or CVS sampling, that any bleeding in pregnancy, you guys, or trauma during pregnancy, any attempts to manually turn a fetus, so he or she is head down. We talked about that earlier. That would also call for an additional dose of RhoGAM. So please make sure that you're feeling comfortable with this information. We got a lot of good information on these slides with this. So hopefully we did a good breakdown to help simplify that for you. Again, we want to make sure that we catch this. These are some obvious, I don't want to say obvious, but some signs of a baby not making it because of fetal hydrops or that RH isoimmunization. So there are some pretty significant health problems that can result from this. So what we do, again, is that antibody screening test, and then we're going to make sure to administer that RhoGAM to a woman who's RH negative at 28 weeks. And then we'll check baby's blood type. And if baby is RH positive, then we're going to give another dose of that RhoGAM within 72 hours of birth. Okay. If baby is negative, then we wouldn't need to give her another injection of RhoGAM. The other thing that I want to hit is group B strep as well. This is another type of testing that we're going to do at that 36-week visit. This just consists of so group B strep is a type of bacteria. It tends to occur roughly in 30% of women where this like specific bacteria is colonized in the vagina and rectum. So it's a bacteria that's kind of part of our natural flora, you guys. But again, in roughly up to 30% of women, sometimes it's found in that vagina and rectum. So it doesn't really cause too much of an illness for us. However, it can cause infections to baby. So if the plan is a vaginal birth, we don't want baby exposed to that. So that's why we swab them to see if there is any of this bacteria in that vagina rectal area, because we want to make sure that if it is present, that we're going to start some antibiotics to kill that bacteria off so baby doesn't come in contact with it and get sick. Some problems that could result if baby does come in contact with that are things like pneumonia, meningitis, as well as sepsis. So it's not a something that we want to mess with. It's rare that a baby will get sick, like it's not super common, but we don't want to take that risk, okay? So for this test, again, it's going to occur around that 36-week time frame. You can see on the slide here, we talk about between that 35 to 37 weeks. What we're going to do is take the swab and we're going to swab the vaginal introitus followed by the rectum. So again, just kind of inserting the swab just slightly through the anal sphincter, but you don't have to like stick it really far in. You, depending on what like your facility has for supplies, you'll either use one swab for both areas. So obviously you're going to want to swab the vaginal introitus first, follow with the rectum. Otherwise, if you have 2 Q-tips per the container, and I think you can kind of see that maybe in this one, then you're going to use one for the vaginal introitus and one for the rectum. So the other thing that I wanted to kind of talk about with this one is, again, if it is positive, you guys, we do want to make sure that we're going to educate and talk to her about starting some antibiotics so that way we're not exposing baby to that. The other times that we would just give antibiotics is if at any time they have group B strep in their urine, like we identify it in their urine, then we will just tell them like, hey, during your labor process, we're going to actually give you some antibiotics. The other time that we would administer these antibiotics is if they have a history of a previous infant with CBS sepsis or infection. So not that they had GBS, but that their baby got sick from it, okay? And then the other times that we'll hang antibiotics is if somebody comes in and they're in preterm labor and their group B strep status is unknown and they are running a fever. So if they're showing any signs or they have like prolonged rupture of membranes, we're going to want to give them those antibiotics as well. Keep in mind that GBS, like this test, we're going to want to do it with every single pregnancy, just because in your previous pregnancy, you could have been positive, but in this pregnancy, you might be negative. So making sure that we do test every single woman with every single pregnancy, okay? So again, this is just covering some more information about Group B strep, how we might want to explain it to the woman, making sure that we're helping her understand that it's like, again, normal flora, part of our normal flora, and that it's not like anything like a sexually transmitted infection. Again, it can be found into up to 30% of women. Again, with baby getting sick, it is rare and it can happen, up to like 1 to 2 babies out of 100 when mom does not receive antibiotics. And then that risk is even further reduced, you guys, for that neonatal infection when we use those antibiotics. So hence why it's really important that we identify those people that might be at risk for their babies getting sick and wanting to get those antibiotics going. This also covers kind of some what you would expect for infants if they were exposed, kind of that early onset as well as that late onset, and then has some other information regarding the antibiotics we'll use on this slide. So usually we're going to use penicillin antibiotics, but if she has an allergy to that, like maybe like a mild hypersensitivity. Maybe she just gets like GI upset, or maybe it's just like a very minor rash. Then we'll use what's called cefazolin. However, if she has like an anaphylactic reaction, then we're going to want to steer away from Cef, because that could be, they could have like a cross tolerance, or people that have like a really hypersensitivity to penicillin could also experience that with cefazolin. So for those people that have those hypersensitivities, such as like anaphylactic, we're going to want to use something like vancomycin. Again, you can see the different cases in which we would give antibiotics as well. So this is a really great breakdown, or kind of like a chart to kind of show the different antibiotics that we would use based off of the penicillin allergy that they have. And again, you can see how our kind of standard is that penicillin, low risk to penicillin, kind of like based off of her allergy symptoms, would be that cefazolin. And then if it's a high risk, how we'd want to use something like clindamycin or vancomycin, okay? So hopefully this chart can help you understand why we would use different medications. Some prenatal complications. So things that we would want patients to report to us in that first trimester would be things like burning with urination, because we want to treat UTI infections, or any other symptoms that could lead to possible like preterm labor, severe vomiting. That would be things like HG, hyperemesis gravidarum. Those women tend to have a hard time gaining weight in pregnancy and keeping food down. It's a struggle, and their vomiting and nausea is really excessive. So it's quite different from your normal nausea and vomiting in pregnancy. Again, the big factor is like they're not gaining weight, and we would expect weight gain with pregnancy. If they're having excessive diarrhea, because we know that can be excessively dehydrating, or if they're having abdominal cramping or vaginal bleeding, because we're worried about miscarriage or ectopic pregnancies. Second and third trimesters. So the things that we would want them to report is just like a gush of fluid, because that could be their water bag breaking, especially if it's prior to 37 weeks. Any vaginal bleeding, any abdominal pain, changes in that fetal activity, Again, persistent vomiting, which could be related to that HG fever, because that could elicit possible infection. Pain when you're going to the bathroom, or that burning, because that could tell us that she's got an UTI going on. Any symptoms that could be related to preeclampsia, such as like blurred vision and severe headaches, edema of the hands and face. All of that could be related to like hypertension as well as preeclampsia symptoms. Also, if she's having any symptoms of hyperglycemia, we're going to want to know that, as well as hypoglycemia. This slide covers post-date surveillance. So you can see here, post-term is a pregnancy after that 42 weeks. Some risk factors might be if she's had a previous post-term pregnancy or irregular menstrual cycles. The reason why I will do some surveillance is because there's some complications that could occur, such as like oxygenation to the baby due to that aging placenta. There's also a risk of meconium aspiration by the newborn. And then those babies can get really big, you guys. We could have fetal macrosomia, which could lead to things like shoulder dystocia, or needing to use like vacuum assistance, or forceps with the delivery. Or it could even lead to things like your C-sections. So we want to make sure to try to monitor baby and make sure that everything looks good. A lot of the times we'll do biweekly non-stress testing, as well as biophysical profile ultrasounds. So you can see here a non-stress test is us watching baby and the monitor to see how baby's doing. So we ideally want a reactive non-stress test. So that would be the presence of 2 or more fetal heart rate accelerations during a 20-minute period. And we want those accelerations to be 15 beats or more per minute and lasting 15 or more seconds. So please make sure you watch the fetal heart tone lecture recorded by Lindsay, so you guys are feeling good with understanding accelerations and how to assess for those accelerations. A non-reactive would be associated with possible fetal hypoxia. So we would want to make sure to follow up with a biophysical profile if we were getting a non-reactive NST. This slide covers contraction stress tests. We don't really use these in practice anymore, but your textbook was still educating you guys on these, and you might just like have a question pop up about it. So here we just kind of did a breakdown of negative CST, which would technically be a normal finding, and then a positive CST, which actually would be an abnormal finding, and we wouldn't want to see that. So just make sure to kind of read over this slide and feel familiar with it. But again, not something really you're going to see in practice as much. And then this is that biophysical profile. So the common one that you're going to see, I'm going to go back here, is these non-stress tests. So again, like I said, if we had a non-reactive, we would want to make sure to follow that up with a biophysical profile. Unless it was like really extreme, then we might even just like abruptly bring her down for C-section or something like that. But if it's something to where we're like, okay, we want to do some further evaluations, then we would jump to like a biophysical profile, which is this ultrasound. And we're going to detect kind of like fetal breathing movements, the fetal movements, fetal tone, fetal reactivity. Again, that would be that non-stress test that was done earlier. And then also assessing the amniotic fluid volume. So I just wanted to kind of do a rundown of what would be incorporated, or what we're looking at with that biophysical profile as well. That is the last slide. So thank you for watching. I hope that you found this informational. Let me know if you guys have any questions. Please bring those to either your next lecture class, or you can email me. Thank you.